This animation describes the use of the harmonic scalpel for the direct anterior approach. The patient is positioned in a lateral decubitus way. Specific landmarks, such as the greater trochanter and the anterior iliac crest, are identified. The skin is scratched with a regular scalpel before using the harmonic scalpel to go through the subcutaneous tissue down to the level of the fascia. First, coagulate any vessels before splitting the ATP on the border with the fascia. Dissect the fascia from the tensor muscle using blunt dissection, working around the tensor muscle down to the femoral neck. A retractor is placed laterally before splitting the fascia, and the yellow fat pad is moved to the medial side. The capsule is now visible. The capsule is first split longitudinally down to the intratrochanteric line, where it is released in a T-shape from the femoral neck. The labrum is then split from the top in order to facilitate dislocation of the head. The femoral neck is cut without dislocation on the level of the templating. A corkscrew is first inserted on the lateral side in order to flip the femoral neck to the front. The corkscrew is then inserted into the femoral neck longitudinally. With the corkscrew fixed in position, the femoral head can be easily twisted and dislocated. For reaming, placement of the trials and the final component, the surgeon is orientated on the transverse ligament and additional local landmarks. In this animation, a pinnacle cup with a delta ceramic shell is inserted parallel to the transverse ligament. For insertion of the femoral component, the leg is placed into hyperextension and external rotation. Before opening the femoral cavity, it is critical to have a complete overview in order to exactly locate the femoral opening. Broaches are then used to enlarge the cavity. The level of the implant is measured against the greater trochanter. The distance has been templated preoperatively. At this stage, it is recommended to use trial components in order to check stability and range of movement. The trial components are then removed and the final components, in this case a Karai stem, are then inserted. The final height is checked by taking the measurement of the distance from the implant to the greater trochanter. Bone from the femoral head is used to bone graft any gaps that may appear between the cortical bone and the implant. In an anterior approach, this is usually on the anterior side of the femoral neck. The final ceramic head is inserted and stability is checked once more before closing the capsule, first with single stitches and then a running suture on the ATP.